Welcome to Kauai Delta. My name is Brenda. I'm the manager here of 4 Tower. All of the staff at Kauai Delta will provide excellent care for you. The purpose of this video is to help you understand what will take place during your stay here, before, during, and after your surgery. You will meet some of the staff who will be your caregivers, and they will give you some of the explanations. At any point during your stay, any of the nurses and staff on 4 Tower or in the CVICU can answer any of your questions. Our goal is to provide you excellent care throughout your stay, and I know that the nurses here will meet and exceed that goal. Thank you for coming to Kauai Delta.
My name is Joe. I'm one of the 4 Tower nurses. Now that you are admitted to the hospital, a nurse will explain all the preparations needed for your open heart surgery and explain the plan of care for after surgery. Questions are always welcome. Today we'll draw some blood work, obtain a urine sample if not already done in the office. A chest x-ray, EKG will be done, and a respiratory therapist will be by to show you all the exercises that are needed for after surgery.
Hi, I'm Cherish. I'm going to be your aide for today. I will be taking your vitals, having you take a shower with antibacterial soap, and after you get out of your shower, you will be putting on a gown. After your shower, you will not be able to use deodorant or baby powder. The following morning, you will be taking another shower, but before you take your other shower in the morning, you will be getting clips from head to toe, which that means that you will be having your arms shaved, your legs shaved, your middle part of your body shaved, as well as maybe a mustache if you have one.
Hi, my name is Astrid, and I'm one of the nurses here on 4 Tower. I'm going to tell you a little bit about the surgery itself. You might have one or more blockages in one of your coronary arteries. The cardiac surgeon is going to get a vein from another part of your body, and it can be from your chest or your leg. What he's going to do is he's going to suture the upper segment in the aorta, and then he's going to suture the lower segment right beyond the blockage on the coronary artery itself, therefore creating a bypass. You might also be here because of valve issues. If possible, we try to repair the valve. In some cases that is not possible, then we will replace the valve. The valve can be replaced by a biological valve, which is a valve made out of tissue, or a mechanical valve, which is a valve made out of mechanical parts. The choice of the valve depends on your age, your body type, and your lifestyle.
Hi, my name is Eugenia. You can call me Jean too for short. I would just like to let you know that before surgery, you will be picked up 60 minutes before surgery, and after that moment, your family will be with you. When you get picked up for surgery, your family will be asked to wait in a waiting area, which is at the 3rd floor. And Julie, our coordinator, will give you updated about the progress of the surgery.
Hi, my name is Erin. I work here in Cardiac ICU here at Kauai Delta Medical Center. I am one of the open heart recovery nurses. I'm going to tell you a little bit what you'll be expecting when you come back from surgery. You will have a breathing tube in place. This is the ventilator, the machine that will be assisting your breathing. You'll also be on IV medications. This is an example of one of the pumps. There'll be multiple pumps behind you. Equipment helping your heart. Once you can breathe on your own and are a little bit more awake from open heart surgery, we will remove the breathing tube. You will also have chest tubes that are in place that will be coming from your sternal area, and those will be in place for at least 2 to 3 days. And then you also have a Foley catheter that will allow you to use urinate to drain your bladder without movement. And you can expect to have the breathing tube removed within 6 hours. That is our goal, 6 to 24 hours to get that breathing tube removed as you heal. And after you are extubated and your main line is pulled out, you will be mobilized, you will be sat up in a chair, and you will be ambulating, walking throughout the unit.
Hi, my name's Carrie. I'm one of the nurses on 4 Tower. When you leave the ICU, you will come up to 4 Tower. You will have chest tubes, you will have a Foley catheter, and you will most likely have your pacer wires still in place. Usually you have your Foley catheter taken out at about 24 hours after you arrive, and that is to help you start moving. We're going to have you on a fluid restriction. That means we're not going to give you a whole lot to drink, but you will have plenty. We are going to give you diuretics, which is also known as a water pill. We want to move those fluids. You're going to be kind of puffy, and you're going to have a lot of extra fluid, which you get in the OR. And it's going to be our goal, as well as your goal, to get rid of some of those fluids. We're going to do that by the use of diuretics, restricting your intake, as in fluid intake, and we're going to get you up and walking. We will have you up in a chair for all meals, breakfast, lunch, and dinner. We will also have you up ambulating at least, multiple times throughout the day with physical therapy, with your nurses, and with your nursing staff. Now we will be showing you a short video produced by Physical Therapy describing what you will be doing in your recovery.
This is a training video on sternal precautions and the proper handling of patients following open heart surgery. The general precautions given to the patients after surgery are: no pulling, no pushing, and no lifting more than 5 pounds. 5 pounds is roughly half a gallon of milk. Patients should limit arm motion if pain is present. They should not sleep with their hands behind their head, and they should hug their heart pillow to their chest to help remind them not to use their arms and aid in coughing. These precautions should be followed for 6 to 8 weeks following their surgery, and they are important so that the patient can reduce the risk of improper healing of their bone and incision. The first item we will be addressing is bed mobility. We will address the proper sequence in getting a patient out of bed safely without breaking their sternal precautions. From the supine position, have the patient cross their arms across their heart pillow so that their elbows are not touching the bed. This will help prevent them from wanting to push with their arms. Also have them bend both of their knees up. The patient should look like the individual in this picture. Next, have the patient roll towards you. Make sure they keep their knees bent. You may assist the patient with rolling by placing one hand on their upper back and the other on the side of their thigh, as shown in the following photos and video clip. It is important not to pull on their arms so that you do not break their sternal precautions. Once the patient is lying on their side, have them place both of their legs over the side of the bed. Notice the placement of your hands in this picture. They should be repositioned so that they are both on the upper back of the patient. Instruct the patient again not to use their arms and to pull their legs against the bed to get into the sitting position. With your hands already placed on their upper back, you are in a good position to assist them into sitting without pulling on their arms. Here are all the steps to get from supine to sit put together. To get back into bed from the sitting position, it is basically the reverse process from getting up. First, make sure the patient is sitting closer to the head of the bed so that when they lay down, their head will be on the pillow. Again, make sure the patient is hugging their heart pillows so they are less tempted to use their arms. Your hands will be on their upper back of the patient, just like when you're helping the patient get into sitting, as shown in the following photos. Help guide the patient onto their side, and as they are contacting the bed, begin to have them roll on their back. This small amount of rolling will help bring their legs up onto the bed. After you have laid them down, you may then help the patient finish bringing their legs onto the bed or reposition them if needed. Here is the entire process from start to finish. Now we will adjust transfers. First, have the patient scoot to the edge of the bed or chair. This will make the sit to stand much easier. They can do this by wiggling their way forward using just their legs. With some patients, you may need to manually assist them by pulling their hips forward on the bed. With sit to stand, you want to position yourself on the side of the patient with one hand on the middle of their back as demonstrated in the pictures, and your other hand over their pillow and crossed arms. You want to firmly but gently squeeze them between your arms to help support them with standing. Instruct the patient to bend forward and get their nose over their toes. It is often beneficial to do a 1, 2, 3 count where the patient rocks forward with each count and then stands on 3. Your positioning on the side of the patient also allows them to have more room of getting their weight forward and easing the transition from sit to stand. For patients who require more assistance with standing and transfers, there is an alternate position which will be covered next in the stand pivot transfer section. If the patient is unable to take very many steps or requires a lot of assistance, it is better to stand in front of the patient. Use your knees to block the patient's knees from buckling and place both of your hands on the back of the patient below their rib cage so that you can have good control of the patient. Again, follow the same procedure for getting up by rocking forward using the 1, 2, 3 count and standing on 3. Once in standing, you can then pivot you and the patient together, either into the bed or to a chair. Stay close to the patient during all transfers to improve your control, stability, and safety of the patient at all times. Once the sitting surface is behind the patient, slowly lower them into a sitting position. If you are going to walk the patient, first make sure they are wearing a pair of no-slip socks and have a second gown covering their backside. Maintain close contact with the patient to ensure they don't fall or lose their balance. Remember to walk slowly and not overwork their heart. If you are walking a patient in the 6 to 8 weeks following their open heart surgery, be aware of what assistive equipment you may use with the patient that does not interfere with their sternal precautions. That means patients are not to use any type of assistive device for walking, such as a walker, cane, or crutches. These all require more than 5 pounds of force to be used through their arms. In the acute hospital and rehab, cardiac walkers are discouraged. Only use with caution so that the patient is only lightly resting their arms on it for balance and not putting weight through their arms. Now that you have learned the correct way to work with patients following cardiac surgery, it is important to point out the common mistakes that many people make that are not safe. Each of the following photos and video clips demonstrate bad hand placement when assisting the patient because they cause you to pull on their arms, in a result breaking their sternal precautions and putting the patient at risk for not healing properly. This concludes this presentation on sternal precautions in the cardiac patient.
I'm one of the respiratory therapists here at Quia Delta that will be helping provide care for you after your surgery. When you come into the hospital, when you get admitted, you will have a respiratory therapist come into your room and give you a little bit of education. One thing that we will do is we'll do a pulmonary function test, a bedside pulmonary function test on you. It's a little test that takes about 5 minutes, and it kind of just gives us an idea of how your lungs are and just gives us kind of a baseline surgery. This device is called an in-center spirometry, and I'm going to show you how to use it. You're going to put it in your mouth, and you're going to take a big deep breath, a slow deep breath on the mouthpiece. So you want to exhale all your air, and then you'll suck in on the mouthpiece, and you want to see how high you're getting the white marker at the same time keeping the yellow little marker in the best zone. It's just a slow, steady breath. And you keep it in the best zone, and then what we'll do is we'll put a marker at where you got before surgery, and we want to get you back to that before you get out of the hospital. So your respiratory therapist, when we come in every 4 hours, will give you breathing treatments, and we'll do your in-center spirometry with you. The nurses will also do it with you in between your treatments, and I always encourage family members, if you're in the room visiting your family member and we're not in there, patient's not doing anything, have them pick it up and breathe 8 to 10 times on it every hour or so. The more you do, the better. So it's very important that we're doing this.
And at the same time, when you do your instrument spirometry, you're going to have a little heart pillow. And you're going to use this heart pillow and you're going to put it on your chest and you're going to put pressure on it that we call splinting. You're just going to put a little bit of pressure on your chest when you use this, when you take a deep breath, when you cough, when you sit up in bed, when the nurse wants you to roll over, any kind of movement while you're here in the hospital, you're going to want to put this pillow on your chest and just put a little bit of pressure on it. It's going to help with the pain and then help with that incision there on your chest.
After surgery, your bowels may be a little sluggish. You may not pass gas or your bowel movement as fast as usual. Moving around will help you avoid bloating. We also offer laxatives and stool softeners to help you.
Now we're going to discuss your pain management. Pain is a very important part of your recovery. You will not be completely pain-free, but we will control your pain. It is going to be up to you to let your nurse know what your level is. We will ask you multiple times what your pain level is, and we want you to rate it on a scale of 1 to 10. 1 being the least, 10 being the worst. We will also be giving you oral medications to control your pain. We don't want you to be afraid to not take them. You will not become addicted to them, and they will actually help you in your recovery. As long as you're taking your pain meds and you control the pain, you're going to want to get out of bed, you're going to want to move, and those kinds of things, which is all going to lead to you getting discharged from the hospital and doing much better. If you don't take your medications, you're not going to want to deep breathe, you're not going to want to get out of bed, you're not going to want to walk. So it's imperative that we control that pain, and we need your help to do that.
Every morning, the doctor and the nurse will assess you, and they will make adjustments to the plan of care for that particular day, until one day you will be ready to go home. The doctor will write the discharge orders, and the nurse will go over all the discharge paperwork with you, which includes follow-up appointments, all the home medications that you need to take care of, and also what you are able to do physically. If possible, we would like a family member to be present during the discharge. We will also set up home health for you.
Hi, I'm Roger Murray. I'm the president of Tulare County Mended Hearts. We're a support group that consists of cardiac patients that meet once a month, and we have professionals that come and speak to us about our cardiac issues and provide us with guidance and information, and a Q&A session for the type of issues that we have relating to our heart. Within our membership, we have volunteers that are cardiac patients, and they will come and visit you before and after surgery. These are folks like myself that have had bypass surgery, and they can relate to you on the type of issues that you will confront or the type of questions that you have from a patient's perspective instead of from a professional perspective. I know that you have anxiety right now. I had the same thing. Let me share my story with you. 9 years ago, after 6 stents and numerous angioplasties, I elected to have bypass surgery. And after my surgery, I woke up and I had a Mended Hearts visitor at the foot of my bed. And the Mended Hearts visitor was there to assure me that I was going to be fine. Because of him and his encouragement, I have decided that I wanted to visit open heart patients. I have done that now for the past 9 years. And I just want to assure you that you're going to be fine. You're on a full road to recovery, and you're in good hands here. And I look forward to seeing you at one of our upcoming Mended Hearts meetings.